Should be a button on the top. All right, we'll go ahead and get started. Can you guys hear me?
Doesn't seem so.
No. All right, we're going to go ahead and get started. Welcome back to CPC January 2025 edition. We're almost to Funuary. Happy January 17th, everyone. And for those of you zooming in from the interview day, welcome. These are our disclosures, and aside from the IBM and Verizon stock that Carl owns, as usual, there is nothing. And I assure you that this is not a telecommunications case. All right, so today we do have an interesting case, and we'll talk a little bit more about the one-liner in a second, but we always like to touch on the history of CPC first. And so this is actually a conference that started at Harvard. It was based on how they did and dissected law cases, and was brought by Dr. George Dock in the 1950s to WashU. And so it's been a staple here, and is something that we do every Friday. We have food and awesome conversations with attendings going through a case. And so this has been one of the favorite conferences and long-lasting conferences that we've had here at WashU. So we'll start with meeting our expert, Dr. Meurer here, and now we'll turn our attention to our case. So we have a 20-year-old female with a history of asthma coming in with early satiety, bloating, and abdominal pain. And we'll start with your initial thoughts.
Yeah, sounds good. So I guess just right off the bat, if I were to take that initial prompt at face value with no other kind of context, the most common things you would start to think about are functional dyspepsia, maybe gastroparesis. You'd be screening for alarm symptoms that would delve you into other differentials. But, throwing into some context that you're asking me as a liver specialist and that I'm here on the CPC stage, of course, we're going to take a deep dive and talk about some zebras that you have to consider. Adding a liver focus to this, someone this age presenting with these complaints, one parsimonious diagnosis could be Budd-Chiari syndrome if her bloating ends up being ascites, an actual distension rather than just subjective sense of bloating. And then just thinking through how I piece apart this stem altogether. So, a young female, I do start to consider, is this, genetic or metabolic pathophysiology that could come into play at her being a young adult. Gynecologic pathology, so endometriosis can be a bad player and can mimic a lot of things, can disseminate and actually have liver involvement and present in a myriad of different ways. Of course, pelvic inflammatory disease, Fitzhugh-Curtis could be a liver link and present potentially with these GI symptoms. Of course, not to forget pregnancy, and I'm sure that was ruled out early on, hopefully, but maybe this is a liver disease and pregnancy case, so you never know. If I think about comorbidities, as a liver specialist, I do always try to focus in on the comorbidities that my patients have and how that might play into their liver manifestations. If, again, I take the diagnosis of asthma at face value, and that's a correct diagnosis, maybe there's another atopic condition, a hypereosinophilic, again, if we're chasing zebras, a hypereosinophilic syndrome can have GI manifestations, can have liver manifestations, could explain someone's underlying asthma. If perhaps the asthma is not a correct diagnosis and I need to think about other liver lung disorders, again, we can go and delve down into all of that. If she ends up having more emphysematous changes, alpha-1 antitrypsin would nicely couple a liver pathology as well as someone with lung disease, sarcoidosis, telomere disorders. Could also couple the liver and the lung. There's several different lung manifestations of portal hypertension that can come into play. And then my only other thoughts as I'm just thinking through this is, we are gastroenterology trained and then subspecialize in liver, but the two, can often coexist, and a lot of conditions can couple GI and liver processes. So one thing, when a patient of ours comes to us as a liver consult and the abdominal pain is the predominant symptom, one teaching point we always highlight is that the hepatocytes themselves do not have pain innervation. And so if pain is predominant, we're often looking at the biliary tree, pancreaticobiliary, vascular etiologies is the peritoneum, the cause of the pain, because we can't blame a primary liver process necessarily on the pain component alone. And then I just listed off some associations to always keep in mind when it comes to GI symptoms and liver, issues, PSC and IBD obviously are very closely linked. Autoimmune pancreatitis and IgG4 cholangiopathy could couple these things, and you see the list there as I'm thinking through. Another thing to consider is mass effect. If she ends up having a liver mass, this can encroach upon the stomach, lead to gastric outlet obstruction, could lead to these GI symptoms. And this could be benign or malignant. In someone who's a 20-year-old female, I would really consider hepatic adenomas, and she could have adenomatosis that can cause these type of symptoms. So a lot of rambling, but that's kind of where I'm thinking about as I'm looking at this case. So what I would like to know next is really kind of a detailed history and physical clues about the pain, associations with the pain. Are there any red flag or warning type signs? So weight loss, GI bleeding, family history that's worrisome, and then any clues about chronic liver disease or where the liver part comes in.
Yeah, no, I think that's awesome. And I think you touched on the fact that this is relatively nonspecific abdominal pain and bloating, something we see all the time, and keeping in mind an immensely broad differential. And so to give you a little bit more context, and again, this is not a ton, but 2 months ago, the patient went to urgent care and, like you initially touched on, was told that she had IBS, given some Miralax here, you'll feel better, and something that we see a lot. And typically these symptoms go away. However, her symptoms did not. She continued to experience progressive abdominal distension and discomfort despite this aggressive regimen, and kind of got to the point where even small amounts of food would cause an increase in abdominal pressure, was just generally uncomfortable, and due to the persistence in symptoms, presented to an outside hospital. To just round out the rest of our history here. So again, just a medical history of asthma, no surgical history. You see the family history here and social history as well. And the only medication at present is a birth control patch. On review of systems, the patient reports fatigue and shortness of breath. The shortness of breath really has to do with just feeling like she can't take a complete breath, and is having a lot of abdominal fullness, distension, pain, and nausea. So with that in mind, any additional thoughts based on, I know, relatively limited additional history?
Based on the abdominal distension, was there any tympani assessed? Like, what did you feel like this was gaseous or not? Those are the things that I think about when I'm looking now, but it does seem like more than bloat, there's physical distension that's possible. And then any organomegaly, or clear evidence of that would be something that I would want to clue in on as well.
Yeah, and so the team noted diminished breath sounds in both bases and also a distended belly. There wasn't a lot more detail other than this reported within the physical exam, but we'll get some more context soon.
Okay, sounds good. So then this does shift my mind a little bit about, if there is physical distension, then thinking, is there ascites present? That's kind of key as well. And then organomegaly. So right off the bat, having, and also these symptoms have progressed, and they do sound pretty significant to where they're impacting her quality of life. We'll have to see if she had lost weight or had other red flag signs, but this is cluing me in that this is someone who is, sicker than, they were initially kind of felt to be at first, it seems. And so I would start off with some basic labs and probably imaging.
Yeah, so we'll start with the basic labs. And so could you take us through how you would, sort of interpret these, in particular the liver?
Yep. Okay, so looking for it, I mean, so you see the liver test abnormalities are cholestatic pattern, but fairly mild. Your bilirubin is elevated predominantly in a direct component. Your albumin is low though, which is pretty striking for a young woman. So that is an important point to not gloss over in my mind. And then you see the alkaline phosphatase. The aminotransferases are normal. And then you can see that her bicarb is low, really quickly calculating an anion gap. I don't know if I'm going to do the math on the spot, but she has normal renal function. Let's see, do we have a total protein? Yeah. So no protein gap. So kind of a cholestatic type pattern that's mild. So I would want to make sure, as I pointed out earlier, that I'm getting some imaging to look at the biliary tree with the abdominal pain complaint.
So sort of honing it on the right upper quadrant based on physical distension, and then further more objective evidence that the biliary tree may be involved.
Yeah.
And this is the CBC, just notable for a microcytosis. She does have a history of menorrhagia, which is why she's on the birth control patch, and so known history of iron deficiency anemia in the past. So where would you go first with your initial diagnostic, sort of based on what we talked about?
Yeah. So, quick and easy, I would start with an ultrasound. A lot of times we do end up adding in Dopplers to assess, especially with the pain component. So I would start with the, liver ultrasound with Doppler. That's usually where I would go first.
So what I can give you actually first is we have not a right upper quadrant with Doppler yet. We have a right upper quadrant that was done at the outset hospital. And this offers a little bit more context to why she was transferred to our institution. And so this was sort of the initial imaging studies. We did not have the images here. This is just the report that you see in the chart.
Okay, got it. Okay, so importantly, there's no biliary ductal dilation. It looks like there's potentially evolving acute on chronic cholecystitis. Again, you said we don't know what parameters they're basing that on, but the liver appears normal in echo texture, but prominent in size. So assuming it's a little bit large, and there is ascites present, which obviously is it now helps us in thinking through the case and hones in on the differential, and then a right pleural effusion as well. Okay, yeah, so that's helpful. And so this again, in this type of patient, 20 years old, I now have new ascites, right? Then this changes how I think about the case in general, and ascites fluid analysis is going to be the first step that's going to really help us and delineate, is this portal hypertension driven or not? So I would want a diagnostic and therapeutic if needed, paracentesis, and we'll send that for albumin, total protein, cell count differential, and see what that yields. But again, thinking back at the differential, Budd-Chiari syndrome and making sure we look at the vasculature still does come top of mind. And then after we see the fluid analysis, we could decide if we need to do, where other kind of places we need to go.
And this was also the one other piece of imaging that was actually done prior to transfer.
Yeah. And it's a good point. I think a lot of us will often keep chasing the bile ducts when pain is a predominant component, again, because we're looking to exclude pretty definitively a biliary process. Do we know, is this an MRCP then without contrast, like a pure MRCP?
I believe so.
Okay. So looking through this, okay, so most accentuated right anterior posterior liver lobes. Okay, so concern for a diffuse malignant infiltrative process. So it would be important to understand what type of dynamic imaging this was or not. If they're calling this out, then it may have been contrast enhanced, but dynamic imaging would be helpful to kind of figure that out. And also, if there was contrast, we would have a good look at the vasculature as well. So that piece is missing here. But again, we redemonstrate ascites, and then the stomach, some wall thickening and collapse. Okay.
And so you talked about the ascites first, and so I can give you our results of our paracentesis.
Okay, perfect. Okay, yeah. So looking through, so right off the bat, the cell count. Do we have the cell count?
I'm sorry, I didn't put the.
Oh, that's okay. But we're going to assume, okay, so non-nutricytic, that this is not infected, and then high SAG. So we are looking at a portal hypertensive based source for her ascites, and the total protein is greater than 2.5. So this differential then does, force us to think about post-sinusoidal, post-hepatic processes. So, cardiac, constrictive pericarditis, all the way down then to hepatic vein occlusion. Again, Budd-Chiari syndrome would still be on the differential here. And at the order and at the level of the sinusoid, sinusoidal obstructive syndrome could lead to high SAG, high protein ascites. It would be a little unusual in this young woman without other medical issues, but that's all on differential. And that would be, again, where I'd focus my energy.
And can I ask, with the protein being above 2.5, one thing I've always struggled with is, why is that a difference?
Yeah.
Like what is it pathophysiologically that causes there to be an elevated protein when it's post the liver.
Yeah, it's felt that just that the hepatic sinusoids themselves are not involved in the process, and that it's post that process, so the protein can just weep out. Yeah, although we use it as sort of a very dogmatic reference, we do see patients who have run-of-the-mill cirrhosis and have high protein ascites. So it isn't as, you know, as hard and fast a rule as it should be, but
Yeah.
that's generally the thought process.
Is it weeping out of the liver, or is it
Yeah.
weeping out?
Mhm.
So it's
Still
weeping out
around
of the
the liver.
liver. Okay, I see. All right. So where would you go from here once you have the ascites, and what would be sort of your next steps?
Yeah, so at this point, I would want imaging to look at the hepatic veins and most likely an echocardiogram as well.
So we will get to the further imaging. This is our initial cardiac evaluation as well. And are you doing this based on the elevated protein and
Yeah.
just making sure we rule out
Yeah.
any other further kind of upstream causes?
Yeah, and then you know, also back of mind, we're always thinking, does this person have chronic liver disease? Do they have any clues that, you know, they have cirrhosis? And so I'm sure that, you know, chronic liver disease labs and that workup was likely sent as well.
Yeah.
But I would, you know, yeah, okay, perfect.
Yeah, so this is our initial workup. I
Yeah.
am curious, you know, when you are faced with a patient, and granted, this is more of a cholestatic pattern, but we often get patients with elevated liver enzymes. At what point or how selective are you in sending off the test? You know, we typically do a hepatic function panel along with the hepatitis panel.
Yeah.
And then we think about sending things like Wilson's disease testing,
Yeah.
iron testing. How selective are you? And in particular with the autoimmune pathologies, are you
Yeah.
sending off ANAs on all comers with elevated liver enzymes for the first time, or how selective are you?
Yeah, that's a good question. So when I'm thinking about the liver stamp or the comprehensive kind of evaluation and labs for chronic liver disease workup, you know, I think it is, I am a little more selective. So first I think about the patient in front of me. If this all is an acute process, right, then alpha-1 antitrypsin isn't going to present, you know, acutely as, you know, severe hepatocellular liver injury, right? So if I'm really honing in on a more acute process, I may, you know, not send those type of evaluations. Same with someone who has normal aminotransferases. You know, her pretest probability of having autoimmune hepatitis is pretty low in my mind, and the absence of a protein gap. So I wouldn't go and send, you know, an entire workup on that. Same in AMA is probably low yield in a 20-year-old. It's not wrong to send in a cholestatic workup. And so that's how I kind of think about it, is the acute or chronic, and then the pattern does sway me. So if someone has a completely normal outfloss, I'm not going to check an AMA. Because then you're going to be left with what to do with it. And often, you know, only a small percentage of those patients will go on to develop PBC over the next 5 years. So then you're just kind of stuck in a monitoring window. But looking at these labs, so we see ANA negative, AMA is negative. Her smooth muscle antibody was also negative. Interesting, the CA125 was sent. So this is really, this is a tricky test to send. So it's kind of falsely elevated, or just elevated without any signification, without signifying ovarian pathology or ovarian cancer in patients who have large ascites. So it can be a bit of a red herring, especially in patients who have chronic liver disease and ascites. You know, we really try to avoid that being sent, because it often leads down a dark rabbit hole of misadventure and not yielding anything. Now, in a young person, and when you're thinking through all of this, you know, I can understand why it was sent, but I do think that you have to interpret that with a grain of salt. And then her ceruloplasmin is high, so not low to suggest Wilson's.
All right. And then going through the rest of the sort of workup, rounding that out, all of this was also negative.
Okay, perfect.
So at this juncture, is there anything else you'd like next, or go to imaging?
I still really want to know the hepatic veins. Yeah, I'm still fixated on that.
All right. We do have a radiologist here,
I saw
I believe.
him.
And so I will pass it on to you to take it through. Yeah, please. Thank
He
you.
is our go-to. Oh, yeah.
Yeah, the best radiologist is one who already has the answer, which is the case today. So here are those outside images. which shows a very abnormal looking liver. You can see that it's enlarged. It's going down below the right kidney and very heterogeneous, right? Almost like you can see sort of a texture to it. This is sort of a buzzword for radiologists and hepatologists too. It's sort of a nutmeg appearance to the liver, which makes you think about things like congestion, although the inferior vena cava is not necessarily dilated in this case, correlating with the echocardiogram. If anything, it's narrow. Really don't see normal hepatic veins, and of course, there's moderate volume ascites, no biliary obstruction. I kind of joke around with my residents that the MRI in this case is additional colors, time, money, and other things. But I do think it's additive in this case because it really draws out that nutmeg appearance again and shows this abnormal texture, abnormal T2 signal. Usually the liver is pretty homogeneous on T2, often looks similar in signal intensity to the spleen. But you can see there are areas of increased T2 signal that are probably edema. And also, we really don't see the hepatic vein confluence. You can see the IVC here, but we lose it close to the inferior cavoatrial junction. Again, on this T2-weighted fluid-sensitive sequence, you can see ascites and small pleural effusions. And so really, the imaging findings would be considered very strongly suggestive of hepatic vein or IVC occlusion causing congestion. You want me to keep going? At this point, truth be told, the studies were not interpreted that way. The patient went on for a transjugular liver biopsy. And when they attempted to opacify the hepatic vein, you can see that there's this sort of characteristic spider web appearance when they inject the hepatic vein. Instead of flowing smoothly into the inferior vena cava, there are all these intrahepatic venous collaterals. And then finally, the Doppler that you asked for. Here's the report. I don't have those images, but enlarged liver, hepatic vein, and IVC outflow obstruction.
All right. Yes. So that's kind of what we were would put this case together. And that is. And did you say, was there caudate hypertrophy and kind of changes to suggest the classic? Not in this case. That's kind of one of the classic changes you can see. The caudate lobe can kind of compensate for the hepatic vein occlusion. And sometimes it's even that hypertrophy that just pinches off the intrahepatic IVC and can lead to edema and leg swelling as well. So we clearly have evidence now of Budd-Chiari syndrome in a young woman, and most commonly now we kind of have to hunt for why and start her on anticoagulation and treat her complications of portal hypertension. So she'll need a comprehensive hematologic thrombophilia workup. There was nothing in the history that would make me suggest or would lean, push us towards antiphospholipid syndrome, but I would delve back into that history and see if she's had several miscarriages or is there any other thrombotic events in the past, things of that nature.
Yeah.
But in a young person, and in all patients with Budd-Chiari, you often find one or two different thrombotic disorders that lead to this. It's not a normal place to have a clot form.
Yeah. No, you were on it from the start. And I think getting the liver ultrasound with Doppler, despite even having evidence and a report from an outside affiliated hospital that has a report still being persistent about things that don't make sense and don't add up. Before we get to kind of rounding out the case and what happened and talking a little bit more about Budd-Chiari, we do have our pathologist here, and I would love to hear more about what the biopsy findings show and sort of what you expect to see in this case.
Hello, everybody. Break anything? Awesome. All right. Hi, everybody. I'm Melissa Lemia. I'm a fourth-year APCP resident, and the diagnosis has been spoiled or discovered already at this point. So I guess I'll just go more into the histopathologic features of Budd-Chiari and sort of how that presents. So at a real quick, low power, medium power look, what sort of stands out here is that there's a lot of vascular congestion, a lot of blood like in the sinusoids that really shouldn't be there. We see over here, like in this corner, a little bit more normal looking liver. We see the hepatic plates, about 1 to 2 cells thick is usually what is typically seen and what's expected to be normal. But over here, we see a lot more like empty anucleated spaces. So just hepatocyte atrophy and more vascular congestion over here. So that sort of suggests that like there's some type of backup of blood flow, which can be seen, in Budd-Chiari, obviously. Side arrow. When we go up even closer at a more high power view, we see more blatantly a lot of really dilated sinusoids, these open spaces here, highlighted by these stars. And then in this corner, we see a little bit more of that atrophic liver, and here's a little bit more normal looking liver, again, with some vascular congestion still. Sort of moving into sort of the pertinent negatives, we have here a portal tract with a portal vein, hepatic artery sort of transected here, and a little bile duct over here, and then the central vein that's sort of open here, and a couple other dilated sinusoids over here. Inflammatory wise, we didn't really see anything significant either in the hepatic lobules or at the portal tract. Not very busy at all. No significant bile duct injury. This looks perfectly fine and happy. No steatosis or anything either, like 0% pretty much, so that's pretty good. Okay. And then as part of our usual histopathologic evaluation of the liver, we get special stains, including trichrome and reticulin. You see here the reticulin stain. This sort of highlights along the edges the hepatic plates. And normally it's like 1 to 2 cells, 1 to 2 cells thick. So this is sort of maybe a little hyperplastic, but we see here that there's a lot of areas where it's sort of dropped out, especially over here, a much closer view, where we've got like normal hepatic, sort of thinner hepatic plates, and then the sort of crunched up reticulin that's just sort of bunched up because the hepatocytes that were there are gone, have dropped out essentially. And so it's got a bit of a vaguely nodular regenerative type of pattern, but nothing really like distinctly, well circumscribed nodules or anything like that. And we see here, this is the trichrome. We use this to evaluate for fibrosis and cirrhosis. And we see here that while the nodule, you can sort of still make it out, there's no really bright blue bridging fibrosis or anything that would suggest that this was a cirrhotic process. And then when you go to a much higher power view, you see this diffuse but still pretty delicate pericellular fibrosis. And then this area with the dropout, so it's maybe a little bit more dramatic around here where all the hepatocytes have dropped out. So this is all sort of suggestive of the sort of chronic obstructive type picture that can be seen in Budd-Chiari or in like that venous pathology type situation.
All right.
Okay, perfect. So it's good news for her overall, because Budd-Chiari syndrome can present on a spectrum of things. It can present very hyperacute with even, liver failure, or can present when someone already has cirrhosis and significant, fibrosis that is now not going to reverse if after we, achieve hepatic outflow again.
Yeah. Well, you were on it from the start. It's an awesome job. So one of the things, and I wanted to touch on that, I think that was something that was new to me. When we work patients up in the hospital and we get liver ultrasound with Doppler, I'm always thinking about Budd-Chiari in the context of elevated liver enzymes and acute liver failure, but realizing that this is actually a decently common way it presents the subacute to chronic picture. Yeah. And could you tell us more about why you would expect that caudate hypertrophy that you talked about?
Yeah, absolutely. And I would agree that every case that I've seen so far has presented this way, with kind of a subacute process that's often a misdiagnosis for a little while until it really comes to a head and there's, clinically significant ascites, and then your kind of momentum really goes to find this diagnosis. The reason that the caudate lobe will classically enlarge is because it drains directly into the IVC. So this can bypass the hepatic, obstruction at the hepatic vein level, and try to compensate for this. So that's why you see that classic change.
Gotcha. And prognostically, how do patients do? Does it really depend on their level of fibrosis?
It depends on, the level, well, the initial level of liver dysfunction, and then the long-term, outcomes, how they respond to medical management and how much fibrosis they have. There's several prognostic models that are available that help us not necessarily at the patient level. It's more database-driven outcomes, but looking at, what is someone's transplant or TIPS-free survival when you're thinking about the patient at first. And that's often driven by the degree of hepatic dysfunction they already have. So I'm forgetting if her INR was completely normal, but, you know, some people can present very fulminantly and they may need to have, you know, tips done and more urgent decompression and consideration for transplant as a bridge if they present with significant liver dysfunction.
And to round out the hospital, of course, so there were a couple of attempts at angioplasty, but there were still elevated pressures. And so because of that, she did ultimately undergo a TIPS and has been followed very closely and is doing well. And so, you know, we touched on a number of these teaching topics here. And again, it seems that this presents very subacute to chronic and sort of this kind of more indolent course than something more acute and fulminant. And in this case, she did undergo a full workup for hypercoagulability. Nothing came back positive. They do posit that the oral contraceptives and in this case, a patch was at risk. And this patch is actually a little bit unique in that it does have a black box warning, particularly for people with an elevated BMI, which was not this patient, but the delivery mechanism of the patch can lead to higher concentrations of estrogen and lead to higher risks. And so now has been continued or changed to a progestin-only form of birth control, and has, like I said, has done well since. So thank you very much.